Knee pain is one of the most common complaints in orthopedic medicine. Yet for decades, clinicians looked at the knee in isolation, missing what was often hiding in plain sight. The knee, it turns out, doesn't work alone. It's a sandwich between the ankle and the hip, and much of what goes wrong at the knee starts somewhere else entirely. My guest today is Dr. Christopher Powers, professor and associate chair in the Division of Biokinesiology and Physical Therapy at the University of Southern California, and one of the world's leading experts on lower extremity biomechanics. Dr. Powers has published over 200 peer-reviewed articles with research that has fundamentally reshaped how we understand and treat knee pain, ACL injuries, and patellofemoral dysfunction. His groundbreaking work on hip stability and femoral control revealed that in weight bearing, it's often the femur moving underneath the kneecap, not the kneecap tracking poorly, that drives knee problems. He has served as the president of the Academy of Physical Therapy Research and currently serves as a trustee for the Foundation of Physical Therapy Research. In this conversation, we explore why hip control is essential to knee health, the phenomena of glute amnesia, and how sedentary lifestyles disconnect the brain from crucial stabilizing muscles, and the alarming rise of ACL injuries in children as young as 10 years old. We discuss practical activation exercises, the importance of looking at the whole kinetic chain, and why movement and the way you move is at the root of both the problem and the solution. Welcome to the Live Aligned podcast. I'm Dr. Brent, a doctor of physical therapy, professor, founder of Polestar Pilates, and pathokinesiologist. For over 35 years, I've been fascinated by the dynamic relationship between movement and pathology. On this podcast, I'll host special guests and friends who are making meaningful contributions to help us live aligned and be kind. What do you believe you should be able to participate in? Do you believe there's anything preventing you from participating? Belief is one of the strongest predictors of one's ability. Dynamic alignment extends beyond just the body. It applies to the alignment between your belief and your reality, living in confidence. At Polestar Pilates, teachers are taught to create positive movement experiences without pain that align the belief with reality and restore confidence. Looking to live aligned? Find a Polestar Pilates graduate near you. Go to the Polestar Pilates website, click on Find Your Graduate, and search for a professional in your area. If you're ready to begin your own training, go to the Polestar Pilates website, choose your course, and use the code Dr. Brent. The code is DRBRENT to receive 10% off your tuition. And now, my conversation with Dr. Christopher Powers. Chris, it's good to have you with us today.
Thanks for having me.
Let's dive a little bit into patellofemoral and make our way into ACL injuries. And I think what's so nice for people to understand, and we see this every day coming, especially with our young athletes and especially female athletes and dancers. And what I'm so interested in is really re-educating the hips. You know, we live in a sedentary world. We're deconditioned with our rotators and our abductors just by nature of sitting all day long. But what are some things that you could share with us about the relationship between just the whole lower extremity organization and patellofemoral pain or tracking problems?
Yeah, so let's go back 25, 30 years and the studies that you had mentioned. So what we kind of came across doing these dynamic imaging studies is that when we were looking at patellar tracking, what we noticed was in weight bearing, especially when the foot was on the ground, it really wasn't the kneecap that was moving relative to the femur. It was the femur moving relative to the kneecap. In other words, the track was moving underneath the train as opposed to the train moving off the track.
Mm-hmm.
And that was really the big revelation at the time was the femur, which is half the knee joint, and the femur is half the patellofemoral joint, could move, and it could move independent of the patella. And so, of course, the femur is controlled at the gluteal muscles in particular. And so that kind of opened the door to start looking at hip control as a means to stabilize the knee. And I think the key point is the femur is half the knee. So by definition, the hip muscles control half the knee. And so that got us on a path to really starting looking at hip stability, hip control as a way to manage knee pain.
Yeah.
So, back when we were in school, if you remember, if someone had knee pain, we were just taught to look at the knee. We didn't look beyond the knee. We didn't look at the foot and ankle. We didn't look proximal. But now we teach our students to look at the whole kinetic chain as a
Yeah.
system.
I remember learning to do PNF patterns to the patella for the VMO.
Yeah. Well, I learned the same thing. And we were doing the VMO exercises and, we were taping the patella to try to centralize it. And after a while, we realized, well, that's not really how the system works. And it just really opened up a whole new way of looking at things. And
Yeah.
I spent the rest of my career exploring hip control, hip stability, and not just the knee pain, but for a lot of different pathologies.
Well, you brought so much veracity to it. I think that was, we all had our sort of theories, and especially when you'd come out with the dynamic studies and thinking of like, why did we see the outcome we saw with McConnell taping back in the 90s? And what was it that we were actually seeing? And from the Pilates side of things, we were also thinking, but we weren't quite at that point of understanding the arthrokinematics of the knee and that relationship of the femur to the tibia, the relationship of the femur to the patella, and realizing that what we were actually doing in Pilates is we were loading and working on deceleration of the hip, but we couldn't have put a name to it. We couldn't have put a theory to it at the time. And that was something that you were leading the field in, of being able to define those arthrokinematics. And maybe the tape was, and I don't know if that was true, like the tape's irritating the skin, so we accommodate the femur position up at the hip, and that's why we felt better when we taped the patella. I mean, what was it, psychological?
No. Actually, the tape did have a mechanical effect. So what tape did actually was compress the patella into the femur. And it does increase surface contact area, and it kind of forces the patella to stay with the femur. And if you increase contact area, you reduce joint stress, the joint's more congruent. However, it really wasn't solving the problem because you take the tape off, you're back to square one. So it was really a symptomatic type intervention. It worked. It reduces pain, but it didn't really have a long-term effect on the symptoms because it was not addressing the cause of the problem.
Right. Let's go back to talking about the hip and the hip's relationship, some of the exercises that you were starting to develop or observe that actually did improve that alignment of the femur under the patella. And I think that's the key that we want to be thinking of. If you're dealing with patellofemoral problems, we're thinking more of the long-term benefit by correcting the alignment of the femur underneath the patella.
So we started, I really don't think there's a magical exercise necessarily, but what we've been studying for the last 10 years or so is this whole concept of glute amnesia. So basically the gluteal muscles, the gluteus maximus and the gluteus medius are the key stabilizers of the femur. But what we realized when we started developing intervention programs, exercise programs to address the weakness in these muscles, we realized that a lot of patients just simply couldn't activate the muscle. Like they have a real hard time. The brain is just not signaling the gluteal muscles appropriately to generate a strengthening effect. What have studied for the last couple of years is the fact that there's this diminished neural activation. It's like the signals from the brain are not really reaching the muscle in a way to promote a strengthening effect. And so really what we have learned is the fact that patients have to really learn how to re-engage these muscles before they engage in a strengthening program. because if the muscle isn't being recruited appropriately during an exercise, the patients will feel it in other muscles. For example, the hamstrings. So a lot of these patients with knee pain,
Hamstring cramps.
we're trying to target the gluteal muscles to stabilize the femur. They're doing the hip exercises, and all they do is they feel it in their hamstrings, which is not really the right muscle that we need to target. And so we've kind of developed these activation exercises as kind of precursors to the strengthening exercises. And really these exercises entail isometric holds in different positions to really get patients to
Wake
focus
them up.
in to wake up the muscle. And we've published a couple studies recently showing that doing these isometric holds, the three exercises are the fire hydrant. Do you know that one?
Mm-hmm.
The clam exercise,
Yep.
and the sideline hip abduction. We just had participants do those isometric holds for a week, and after a week, we found a much higher neural connectivity between the primary motor cortex and the muscles. So we were doing TMS to really quantify this.
Yeah, I was going to say, I've recently been going through that for myself. And what I realized is that for years, because of the hip pathologies, I had lost that awareness in my hips, in my glutes, in the glute medius. And I want to talk a little bit more about this idea of losing that connection. I'm a big, big believer in spontaneous activation by alignment and load. And yet we're looking at certain things like I'm sure that I was having proper alignment and I wasn't getting the message to my glutes and the glute medius. It was not getting the message. Is this partly because we're so sedentary these days? Is it because of injuries? Where do we lose this connection? Because children seem to have it.
Yeah, so that's a good question. I have a couple thoughts on this. What we do know is that when you do have hip pathology, there is inhibition. So there's arthrogenic inhibition. And arthrogenic inhibition is when you have a painful joint or a swollen joint or a pathology within a joint, the muscles around that joint shut down. So this is, we've seen this a lot at the knee joint where you have a surgery, your knee's swollen, and you can't activate your quad, right? Same thing happens at the hip. You have a torn labrum, you have hip OA, whatever you have a fractured hip, the muscles around the hip shut down. And that's a reflex inhibition that is common across all joints.
Right.
So number one, the presence of pathology or pain
Cause the inhibition.
can create the inhibition. The second thing is, like you said, I think we're definitely more sedentary. We sit on our butts largely. Muscles that are not used on a regular basis, the brain kind of forgets about it. That's neuroplasticity. The motor cortex loses interest in muscles that they're not used on a regular basis. And it just happens. We only use our gluteal muscles really when we force ourselves to exercise. And, a lot of people who have been sedentary their whole life, they never really have used their glutes. And now they get 50, 60, and they have a hip replacement, and now they just can't find it.
Yeah, yeah.
And it's really interesting when you look at young kids, infants 2, 3, 4, and 5, and you see an infant do a squat. It's like a perfect hip bias squat. And then something happens when you get in the first and second grade, and that goes away.
I was going to bring that up because we played a lot in our family growing up as we squatted on the ground. And one of the things that theoretically is you put a kid in a chair and they go through their growth spurts and they're not having load through the ankles and down in that deep squat. But I remember going to Indonesia and, I was walking with Shelly and we saw these women that were cleaning out a flower bed, right? So they're all just in that perfect squat, just like these little children you're talking about. They've got their lunch snacks, they've got their tea. They stay in the squat the whole time, walking around in the squat, pulling weeds. And we both said to each other, I wonder how long they can do that. Well, 4 hours later, we're walking back towards the rooms and they're still working in another flower bed, but still in the squat position. And I just wonder, if we even had a little bit of that. Like I love to garden, my wife and I love to garden, and that means you got to squat. I haven't been able to do any squat gardening for probably about 5 years. And I just wonder how much of that we take away by putting our kids in a chair at 4 or 5 years old and telling them to sit quietly. and they grow. They grow in that chair, and they're never really back on the ground again unless we facilitate that in our activities at
Yep.
home or and those kind of things.
And I agree. And, there's less physical education in schools these days, it seems like. I think kids play less, and I think that's another key factor as well. And then you add on top of it, now the iPhones and the digital world now where kids don't play as much. They sit on their phones and they do whatever they do, play
Yeah.
video games,
And
and that's a problem.
without being going too far on a tangent, I do want to just say to any parents listening, we talk a lot about getting our kids to have as much deconstructed play as possible in their daily lives. And there's long-term effects of being sedentary and screen time and those kind of things, mentally, emotionally, and physically. But if we can cut it back a little bit. I sat on a board of directors for a School of Arts for Boys, and I got to organize their schedule to have 20 minutes of recess in the morning, 20 minutes in the afternoon. They had 50 minutes of art in the afternoon that was either visual or performing. And then they had sports after school for about an hour and a half. And so their reading scores just exploded. They went up 2-3 levels in 3 months. And on top of that, their behavior was so much better. And we sit there and we talk about all these children with these other problems. But I think that, we got rid of a lot of that just natural playtime. And for me, after school, I didn't go home until it was dark. And sometimes not even then. We were outside playing. We didn't have homework in 3rd, 4th grade. But I know that's a tangent, but it's just saying movement.
But I'm going to tie this in to what I was talking about earlier, is that now these kids who are their movement is not as developed, I would say, but then they get into organized sport when they're in 4th, 5th, 6th, 7th, 8th grade. They start playing soccer, and guess what happens? We have the ACL epidemic. And this is my other area of research. We are seeing ACL injuries in younger and younger kids. This year, I've seen a 10-year-old, an 11-year-old, and a 12-year-old with ACL tears. Imagine that at
It's
that
so
young age.
young.
It's unbelievable. And when you look at how these kids move, it's atrocious. They have no stability. They can't stand on one leg without falling over. And they're playing soccer year round, and they're just injuries waiting to happen. And all our work that we did related to hip strength and control related to patellofemoral pain, it's the same issue in terms of ACL injury. So,
Well, let's go there. Let's go ACL. Let's spend some time there. ACL stands for anterior cruciate ligament. So that is part of the major internal ligamentous structure of the knee. It's responsible for the shearing force that we have that naturally goes through our lower extremity. If you think of any sport, whether you're in the field or on the court or playing tennis, or our favorite sport now for physical therapy making money is pickleball. That's making us a lot of money now. But a lot of that kind of rotational twisting. Let's talk about the ACL. Let's talk about what its purpose is normally, how it should work, and why are we seeing this increased incidence. So take it away.
the ACL is the major stabilizer of the knee. So it resists rotation motions. It resists shearing forces of the knee. And, as I mentioned earlier, the femur is half the knee joint. And really, when the hip is not stabilizing the femur well, the knee is not stable. And when that femur rotates in or collapses inward into what we call valgus, so inward collapse of the knee, that puts a tremendous stress on the ACL. And so we have shown in a lot of our research that hip strength actually is predictive of future ACL injury in a prospective study. So hip strength and control is really a key aspect. And it's really, when I look at my ACL research and what we've done for the patellofemoral joint,
They go
they're
together.
the same person. They move the same way.
Yeah.
They're exactly the same phenotype in terms of a movement strategy. And I think just the movement proficiency in our young kids is just not what it should be.
Should we have these tests incorporated into our preseason screenings? And should we, as physical therapists and athletic trainers, be doing these 4 or 5 really important predictive tests of the hip strength and lower extremity strength? I mean, I think that's one place that we could start, but it should probably start earlier now than we think.
Yeah, I mean, I think all these kids need to be screened 100%. We screen for all kinds of medical things, especially when you get to our age. You're screening for diabetes, you're screening for heart disease, high blood pressure, all the blood work. Why? Because they're risk factors for future cardiac events or cancers or whatever. And we need to screen our young kids in terms of movement proficiency to make sure that they don't develop chronic overuse injuries, or even worse, a major catastrophic injury that requires a reconstructive surgery. And we know that those people that have had an ACL tear in a reconstruction go on to early onset osteoarthritis of the knee.
Yeah.
And so now you're looking at someone in their 30s and 40s that have fairly advanced knee osteoarthritis. And that impacts your life. That's more than just playing soccer in high school. That is a long-term health issue that will affect you for the rest of your life.
Yeah,
So,
I mean, all the things you can't participate in if your knees aren't doing their job.
yeah, I mean, and you stop walking when you're 50, that's not good.
Yeah, no doubt. Those children that were having these injuries, were they complete ruptures or partial tears?
Yeah, they all require surgery. They all had reconstructions. And it's tricky because the reconstruction is, the growth plates are still open, so it's not a straightforward
Right.
reconstruction like we would have in a mature adult.
Would they consider delaying it, or they just have special techniques that they're doing with the consideration of the growth plate?
The ones I've seen were all reconstructed, so
Yeah.
I'm not the expert in terms of the surgical
surgery.
selection on this, but I have heard of situations where people delay the surgery until the growth plates are
Yeah.
closed.
I mean, we know no matter what joint you open up, even if it's arthroscopic, you're going to be predisposed to the osteoarthritic changes earlier. Even as we go talk about, a lot of the listeners are probably also dealing with some kind of osteoarthritic changes, whether they feel them or not, they are probably there. What are some things that you're seeing as ways to improve the rehabilitation, ways to improve function, and maybe make up for the underlying weakness and lack of awareness and proprioception that were probably causing the injury or led to the injury? And how well are these young adults and young children actually rehabilitating these days with your understanding of the full kinetic chain, your understanding of strengthening the femur position and its role in the lower extremity kinetics for their future?
Okay, yeah,
It's a loaded question. I
it's
know.
a loaded question, but I got a loaded answer. So
Okay.
here's the tricky part. So there's 2 aspects of this. And the first thing is you have to address the underlying muscle performance deficit. So basically you got to get the weak
Getting the
muscles
hips.
strong. You got to get the hips strong. Here's the kicker. Just getting stronger, strengthening alone will not change the movement behavior. So it's kind of a misconception that, oh, well, I'm just going to get stronger and magically you're going to be moving differently. You really have to learn how to engage these muscles functionally through movement training. And that is really something that gets missed a lot in our field in physical therapy, is that we're very much strength focused, but we
Do
don't
your
really,
home exercises, your
we don't,
clamshells.
yep, but we don't teach patients how to incorporate that strength functionally. And that's really, I think it's a 2-part process. You got to build the capacity to move well, but then you have to really learn to move in a way to use your hips. And that's the issue. People avoid using weak muscles. That's the nature of how we move. You develop these habitual movement strategies throughout your lifetime.
Right. I mean, we have to be able to re-educate that movement in a functional way and know what that normal is. I think this is what Helen Hislop identified as what does normal look like in these different groups, in these categories, and then how does pathology impact it, or how does faulty movement impact pathology, and vice versa. And I see this all the time, and I teach at the university, and I know it's being taught. I know we try to think that we can get ahead of it and teach our PTs, But it's still like if you go to any clinic, you're seeing these handouts. Now, for us, it's a little different. We're Pilates and we're doing whole body movement and we're trying to do as much upright and standing work as possible these days, and including things like our whole Run-A-T work. I think that's why I went and saw you, was the Run-A-T program that we were doing for running, and was really trying to understand that deceleration load every time we take a step running and that repeated single leg hopping. And if somebody can't do that 30 times in a row, they probably shouldn't be running yet, because they're going to be doing it 1,000 times if they go out and run a mile. So,
right.
What?
Yeah. So that's, I think here's the secret. Muscle weakness does not cause pain or cause pathology. It's the movement that causes the stress and strain on the joint, the tissue, or whatnot. Yes, strength underlies the movement, but really it's the movement that is causing the problem. And where we have fallen short as a profession, I'm going to pick on the PTs here for a second, is the fact that we don't look at movement as well as we should. We're very strength-based, we're very muscle performance-based, but the first order of business is to look, what's the movement pattern and how can I change the movement? What muscles do I need the strength to get you to move correctly, to take the stress off your knee, off your hip or your low back or whatever it is. And teaching athletes how to move, how to decelerate, how to change direction, how to cut is all part of that. And they have to be able to move in a way that they can protect their knee especially. But that's, strength is important, don't get me wrong, but it's just a piece of the puzzle.
Well, we talk about functional strength. Let's finish up, Chris, talking about what you just said. I mean, I think this is certainly my take-home message, is more about movement strategy, movement patterns, having the strength to be efficient moving through space, not necessarily having isolated strength, but the power of moving, the strategy of moving. Like, how can we do a better job from your perspective of teaching motor learning and teaching movement acquisition, especially in our children? I mean, what you said to me sort of shocked me, and is, I'm already dealing a lot with the psychosocial aspect of children not playing and not moving. We know that they're going to have problems have to do with obesity and with diabetes and metabolic disorders. But the fact that we're seeing a super increased incidence of, major ligament injuries in under 12, I mean, that's nuts. I mean, that's a life prescription of misery, at 12 years old.
Yeah, I mean, I just want to point out that I'm seeing this particular injury younger and younger every year, but clearly it's the high school athlete who's at the greatest risk for the ACL injury.
And we didn't talk about gender predisposition, but as far as female athletes, and do we still believe they have a higher incidence of ACL injuries with, court sports and field sports?
Yep. Higher incidence of ACL and knee pain for that matter. So it's across the board. And boys and girls do move differently. That's been well documented. The girls tend to favor using their knee more when they move. The boys tend to favor their hip a little bit more when they move. And not quite sure why that's the case. The different sexes develop that way, but there's been a lot of studies comparing boys and girls at different ages in terms of movement patterns and movement strategies. But there clearly are differences, and we think that the differences that the females exhibit do predispose them to certain knee injuries.
Yeah, I mean, we certainly see a high incidence in basketball and women's basketball. Let's continue down the idea of movement strategy. So, where do we go from here? This can also be directed towards our colleagues in physical therapy, as well as personal trainers, and definitely to the clients to look for somebody that is going to focus on more the movement patterns and movement strategies and the strength, not just the isolated strength.
Well, I think the secret is really in prevention. And we as a profession are in a model of not prevention. You go see your physical therapist after you're injured or after you're in pain.
Tertiary disease management. Yeah.
Exactly. And we really need to be more on the prevention bandwagon. And as I mentioned earlier, we need to screen for certain movement traits that may expose someone to a potential injury down the road. And we need to incorporate some of these strategies into practices. The coaches need to be involved in this. And we really, especially at the young age, when they first get introduced into sport, really educating coaches and parents in terms of what to be on the lookout for. When a young kid comes in to see me in my clinic and their parents are there, the parents always comment, I've always noticed that Susie runs funny. What I mean? The parents notice this stuff.
Yeah.
They notice that their kid is not moving well. They don't quite know what it is, but they know it looks off. And, physical therapists really, we need to get on the prevention side of things.
Well, and this could be a good message to parents that are listening and themselves is like, be the parent that stands up and says, hey, it might be a good idea to get a screening before they start soccer that year. They've grown 4 inches. It might be a good time. I notice that they run with one foot turned out and one foot straight forward. These are all things that, we can do in the community by having awareness, seeing it, and feel like you can address it. If you see any asymmetries, or you see your kids running with their knees and feet turned out, or you see them with knees pointed towards each other, it doesn't always mean they're going to have a problem. It just means that you should probably have it screened out by somebody who knows what they're doing and can give you good advice and some exercises and some movement. I'm thinking of a couple other things that, from a prevention standpoint, it's body awareness. Like Pilates and maybe yoga and Tai Chi often create a body awareness. And then the activity you're going to participate in has very specific demands as well. Now, we're bipedal animals, and maybe that's where it just needs to be part of our elementary education. If you could give 2 or 3 exercises for bipedalness, to put it as global as possible, in the goal to prevent knee pathologies, what would you want to suggest?
Boy, that's a tough one. I don't know if I can break it down into just a couple simple exercises, to be honest with you.
Or maybe an awareness of something. Like what is it that we need to be aware of from your perspective as bipedal animals with bipedal activities?
Well, the big one to be on the lookout for is when the knees roll in. So when you're walking or running or squatting and you see the knees collapse inward into what we call valgus, that to me is a global sign of poor hip control, instability.
Femur's out of control.
Yeah, I mean, as the hip goes, the knee goes. And so I think that's the most observable and common one to see. And that's totally correctable. You get people to be able to strengthen certain areas and to engage those muscles functionally. That can go away. So it is preventable. But, it does take a focused program to do it. It's not like, here, just do this one exercise and it'll magically go away. I mean, it's a process, and
Yeah.
it's something that takes time.
Like, it's not always what you see. And it's like you said, there are a lot of things that we can do as exercises when we see that severe valgus. It's not always a permanent thing.
Yeah, just one more follow-up. There's a lot of research that's looked at prevention, and preventative programs that could be incorporated into soccer practice, for example. We got to get the coaches involved in terms of implementing some of these easy drills that could be done before practice from a preventative standpoint, just to, get young kids moving in ways that maybe they wouldn't move on their own. That's another area that
And I see what's happening too. I mean, I know, like, I have neighbors that are now the soccer coaches for their kids' soccer team, and they don't have a set of drills. They go out there, they volunteer just because they want their kids to be active, and that's what they're going to get. They're doing the best they can. I think that one of the things we want to do in this podcast is to be able to provide resources for these communities and to be able to do that. If there was any of your studies or something like that you would want parents or coaches to read, you certainly can share them with us, and we'll put them into the podcast afterwards. And again, I think number one is awareness. And that's what we're doing here, is educating people that, prevention is worth everything. And any time that we can work with our youth and our, young adults in prevention is worth pounds of cure. And we know that. And I think the other message for our physical therapists is to get off their ass and start doing some prevention in their community and doing some community work. And it doesn't take much. If they picked a couple, especially all of our kids that want to be sports physical therapists, it's like, go volunteer in the community an hour a week and just go in and teach, good drills and things for, knee injury prevention. And they can make a big difference. And if you happen to be the coach or the parent, go find somebody to do that. Like, don't give up on it, because your kids' bodies are not worth sacrificing for something that can be prevented, as Dr. Powers has been talking about today. Any last things that you'd want to share with the community at large about knee health and your wisdom and your experience mainly in preventing knee pathology? Like, what's a take-home message?
The take-home message is, it's really, knee problems are really a lower chain problem. It's the foot and ankle, the knee, the hip, and the pelvis are all interconnected. And I know we were talking a lot about the hip today, but, the calf muscles and the foot and ankle play a role as well. So really, the way you look at it, you really have to optimize lower extremity function. The knee is stuck in the middle of this chain. It's sandwiched between the ankle and the hip. And a lot of times, because of that, the knee gets blamed for everything. But a lot of times it's coming from the hip, sometimes it's coming from the foot and ankle.
Yeah.
And really, you have to optimize lower extremity function. And the day of my knee hurts, well, let's just examine the knee. That's a very narrow way of looking at it. And you'll miss the root cause of the problem. And the pain's at the knee, but chances are the cause of it is elsewhere. So you really need to see a professional. You need to see a physical therapist and be evaluated in a way that is functional and meaningful.
Yeah. This is where finding somebody that you trust, having a relationship with somebody that really understands movement is going to be one of the best things and decisions you make. It's worth, if you got to spend a couple $100 to get a consultation, do it. And if you have direct access in your state, direct access is where you can go directly to a physical therapist. A lot of states have that access. Do it. Like, get somebody that looks at your movement. And that's a good question to ask too. Like, just ask, do you specialize in movement and movement learning? Because I think I have a problem. And, that therapist then, even if they're not the best, they're going to focus on what they've learned on movement dynamics and learning movement, and that'd be better off.
Yeah. And if I can have a concluding statement here is, if you have pain with movement, and a lot of patients come to see us as physical therapists because they're in pain. And a lot of times that pain is associated with, my knee hurts when I walk, when I squat, when I go upstairs, when I run, or whatever. It's a movement problem. And I think people have to realize that it really, how you're moving is really at the root of your problem. And as you said, you got to see someone that you can be evaluated from a movement perspective, and not just a simple flexibility and you're weak here perspective, because it's without changing the movement, you're not changing the problem.
You got to move. You got to move, and you got to move well. Last thing I'll share is just that if you're that physical therapist out there, donate an hour a month or a half a day a month to, do some screenings maybe for folks that do not have access, especially if you're looking at some of the younger sports teams in your area. Like, it doesn't take much. We've always had a little bit of pro bono room to be able to see certain clients that do not have access. And it just makes the whole world a better, kinder place if you can do that outreach a little bit every month. And, educate. We talk about movement, but part of that movement is education. And, if we can provide that, that's the purpose of this podcast, is to provide that education. Chris, thank you so much. I know that our time schedule is different, and I really appreciate you making this work. And
thanks, Brent, and thanks for having me on. It was fun. It was always great to catch up with you.
Thank you for joining the Live Aligned podcast. If you like what you hear, please let us know by leaving a review on your favorite platform. If you have comments or questions, please leave me a message at drbrentanderson.com. You can follow me on Instagram at drbrentpt. To take a deeper dive into the science of movement, check out my new book, Principles of Movement, available on Amazon. Live Aligned Podcast is produced and edited by Gabe Anderson. Music and sound designed by Delver. Special thanks to my team, Elizabeth Jimenez, Melissa Pereda, Cesar Maya, Gary Bentz, and Charlie Zuckerman. I also want to thank the team at Polestar Pilates for sponsoring and supporting us with technology, marketing, strategy, and much, much more. Thanks again for listening. Live aligned and be kind.